Hello, I'm Dr. Anna Chase. My pronouns are she, her, hers, and I was asked to speak to the LGBTQ plus community with substance use disorders. Initially, when presented with the topic, I was feeling a bit overwhelmed. As you can imagine, it's very broad and could encapsulate many different things under that heading alone. But the topic I am most often thinking about and passionate about involving both identities is reducing stigma and improving inclusivity in our practices. Broadly, for those working in healthcare, being thoughtful about our roles in providing support, comprehensive care, and reducing stigma for the LGBTQ plus community with substance use disorders. So starting off, before we get into the meat of the presentation, I have no financial relationships to disclose. And my least favorite slide, but one that I think helps focus us in on this still huge topic, is the slide that describes our learning objectives. So first, we're going to start off with some basic definitions of LGBTQ+ and some buzzwords for social justice that you're going to hear frequently throughout this presentation. I do this to help center the conversation and start everyone off on the same page. Next, we will outline how stigma can limit access to healthcare and then address ways that we in the healthcare community can limit discrimination and create a more inclusive environment and therefore better care for our patients. Beginning with our definitions, we're going to review differences between biological sex and gender. Initially, biologic sex was thought to be synonymous with gender identity. However, now we know these to be two different entities. Namely, biological sex is referring to chromosomes, hormones, and the physical characteristics such as body hair and voice pitch. Gender identity we think about as that inner sense of an individual gender, generally within parameters of available gender options. For example, different cultures have different gender options or descriptions. Here in the States, we tend to think about that binary, but gender identity may align with biological sex, i.e. a person who is cisgender. Gender identity may not align with biological sex, i.e. a person who is transgender. And it's important to note that transgender can cover a wide variety of gender identity and expression, and that extent is not listed here. Gender expression is separate, again, from gender identity. It's how an individual presents through actions and dress, and typically we think about this as being defined by gender norms, and again, this can vary by culture and, of course, time period. For example, in the early 1900s, we would consider pants to be an expression of masculine gender, and now they're considered a more gender-neutral clothing item. Now, separate from gender identity is sexual orientation. This could be emotional or physical attraction. Just as there is a wide variety of gender identities and expression, there are also a multitude of sexual orientations. It can include terms such as bisexual, asexual, pansexual, lesbian, and straight. Again, important to familiarize yourself with these terms and acknowledge that patients may use these terms with a definition different from ones that I've outlined here. Language adapts over time, and we must adapt with it and also respect patients' vocabulary and continue to maintain that culture of inclusivity. Some examples I've listed here of terms that are considered outdated are homosexual and transgender, transvestite. They're replaced with the more accurate and inclusive terms sexual minority, gender minority, and transgender, respectively. Of note, sexual orientation has replaced sexual preference as more inclusive terminology as well, again to reduce wording that implies that sexual orientation is a preference or a choice. Reflecting on the spectrum of sexual orientation and gender identity, they're often lumped together in this LGBTQ+. I've separated them out on this slide to emphasize the wide range of identities that this acronym covers. For example, LBG emphasizes a sexual orientation, and the T is more of a gender identity, as we have just reviewed. These define different aspects of one's identity. So some would argue that this lumping can be problematic or can minimize or erase experiences that aren't explicitly listed. Often you can see this longer acronym here that includes additional identities. This image is from the Safe Zone project and is a free handout. They have a few that are available for your office or workplace. This handout is showing the term queer acting as an umbrella term. It's important to note that transgender is also somewhat of an umbrella term. They have an asterisk marked here on this, if you can see that, because it includes a wide array such as agender, non-binary, transmasc, etc. The plus sign is present often to emphasize that the acronym should never be considered all-encompassing of gender or sexual orientation. Next, I want to briefly review just a few commonly used terms in social justice literature. First off, inclusivity, meaning intentionally making a policy of not excluding individuals based on identities such as gender, race, class, sexual orientation, etc. Intersectionality is the concept that these systems of inequality and discrimination based on these identities, race, class again, intersect, and they can create unique and often compounding effects. Intersectionality will take into consideration that all forms of discrimination are mutually reinforcing and must be addressed simultaneously. For example, in the United States, a cisgender man who is gay and Muslim will likely face more discrimination and minority stress than a cisgender man who is gay and Christian, as he holds two rather than one marginalized identities. The reason this is important is because if we're only addressing one inequality without acknowledging other identities, it can lead to wider gaps in equity and poor outcomes for our patients. Minority stress is emphasizing this on an individual level. Minority stress is a chronic stress that's faced by members who are part of a stigmatized minority group or identity, and this stress can be related to external, objective events or a person's own internalization of societal attitudes. Concealment of one's true identity, whether it be sexual orientation or religion, can also contribute to minority stress. Overall, the goal of intersectionality is to take minority stress and the compounding effects into consideration. Again, I just like to review these at the beginning because I think oftentimes when we're looking at things through our social justice lens, you'll hear these buzzwords and sometimes they start to lose meaning, and it's important to continue to reflect on these concepts. Particularly as healthcare providers, it's important to acknowledge that we are in a position of power and can strengthen or weaken internalized attitudes patients may be holding about themselves. So I did not directly define stigma, but rather broke it down into types of stigma that we think about when we're addressing it. Social stigma and public stigma are often considered one and the same. I spaced them out here just to highlight some subtle differences. Social stigma being more specific to a society or culture, and within that group, referring to negative stereotypes or lower social status, and even separation based on perceived characteristics. This is compared to public stigma when the public is endorsing stereotypes or prejudice, and that can result in discrimination. I think about this particularly for the media, such as news, TV shows, etc., whereas structural stigma has more to do with policies and our institutional practices that can restrict opportunities as well as resources and negatively impact the well-being of certain groups. Self-stigma relates to an individual and when they start to internalize these stigmas, whether it be social or public or structural. On the next slide, I have some brief examples. With structural stigma, we think about disparities in research, housing discrimination, and the criminal justice system, just to name a few. For example, research is very limited on the intersectional group we're discussing today, LGBTQ+ individuals with substance use disorder. Often, these studies only include cisgender gay men and focus on HIV status. Certainly, this erases a lot of experiences and identities. Regarding recovery housing, this is often sorted by gender, limiting access for those whose assigned sex at birth is not congruent with their gender identity. For public stigma, an example that I gave here is the media associating mental health with violence, obviously mental health being another highly stigmatized condition. When thinking of self-stigma, an individual has started to internalize the things that they see on the media and can start to believe that these reflect true aspects of their personality. Examples I think of as a patient saying, "I'm weak and my family would be better off without me," and individuals with depression or substance use disorder, as those are often characteristics portrayed in media and by society. A large component of combating stigma is our language around conditions or identities. So what exactly do I mean by non-stigmatizing language? I think specifically about neutral language, making sure that we're staying up to date on current terminology, so what is considered politically correct and respectful. Some resources I've put in here, and I also have summarized at the end, and that's specifically a dictionary, which has to do with non-stigmatizing language as it relates to addiction. And after we're maintaining neutrally and staying updated, above all else, we want to be deferring to our patient's language. We reviewed all these definitions in terms of gender and sexual orientation. Terminology is constantly changing, and not all patients will agree with these changes. An example I think about is the Q in LGBTQ. obviously we've talked about, it stands for queer. Initially, this was considered a slur, but has been reclaimed by the community and now considered an inclusive term. However, some patients would still find this to be offensive, which is why, at the end of the day, following a patient's lead on terminology that reflects their identity is still considered best practice. Regarding LGBTQ+ individuals, specifically those with substance use disorders, overall evidence is pretty limited. But what is available to us suggests that sexual minorities are at an increased risk of substance use disorders, and that discrimination in the setting of this minority status can lead to an increased risk of substance use disorder as well. The significance between this can vary across age and substance type. A lot of the literature available will divide out tobacco use, alcohol use, and drug use disorders. There's also limited evidence that suggests similar findings in transgender adults. The Growing Up Today study, or GUTS, looked at participants, specifically those aged 20 to 35, and had similar findings regarding use disorders, specifically that they disproportionately impact sexual minorities. I will emphasize that for this study, it was only significant in sexual minorities, and they didn't find similar trends in gender minorities or transgender individuals. However, they did have a significantly less participants in that group that was studied, and therefore less power. The National Survey on Drug Use and Health in 2015 reported that about 20% of sexual minorities interviewed would qualify for treatment, but less than 4% are actually accessing it. So the question remains, what can we do to increase engagement in treatment? The next study is only applicable to substance use disorder population, but reflects a high percentage of patients not seeking treatment as well. Interestingly, about 1/5 of the participants noted concerns about their neighbors or community having a negative opinion of them, again emphasizing that social and public stigma can lead to limitations in healthcare and even just seeking out care. The next study by Kelly has been replicated again twice since this one that I put here, and initial participants in their study were actually mental health professionals who were given vignettes involving individuals that either referred to them as substance abusers versus having a substance use disorder. And then they had participants rate on a scale judgments on personality as well as what outcomes should be for these individuals. Again, I find it interesting. I'd like to stress that the participants they studied were mental health professionals, people who've been trained to work with individuals with substance use disorders, and they still rated that a substance abuser had higher personal culpability and a higher need for punitive action versus someone having a substance use disorder. Now, this study is quoted quite a lot, as you can imagine, and led to increased efforts to improve language within the healthcare system. So we're returning to this slide to reset our focus on inclusion and minority stress. Continue to consider the impact that language can have on reducing stigma and potentially also on reducing compounding minority stress. We should apply this concept not only to patients with substance use disorders, but also to our patients in the LGBTQ+ community. What other barriers might we consider for our LGBTQ+ population? Certainly, lack of targeted interventions. Again, the data is lacking, and therefore creating appropriate interventions can be challenging. There are differences in coping strategies, specifically internalized stigma, can lead to avoidance of assumed negative interactions, discrimination. Psychiatric comorbidities and lack of insurance we know can impact access to healthcare. Patients report discrimination within the healthcare setting, as well as lack of provider knowledge about their individual health needs. And reflecting for today's lecture on these topics, barriers we can address include discrimination within the healthcare system and lack of provider knowledge about health needs. So we've talked about how stigma can limit access to healthcare and why it's important to us to be focusing on this today. We're going to move on to actionable ways to reduce stigma and increase inclusivity and hopefully engagement within the communities that we care for. I think it'd be best to start with reflecting on our own systems, offices, practices. As a patient seeking care, what might happen when they're on your website performing a Google search? What forms might arrive for them in the mail? Where are all the areas they're going to be interacting? What might they see when they come to your office? Who will they speak with? Who are each of the individuals involved in their care when they go to the lab or other areas within your healthcare system? So I tried to break that down even further into this sort of pre-visit category, waiting room, exam room. Now you can imagine that we could expound upon this and include the healthcare system at large, consulting groups, etc. But I've been given an hour for this talk, and so I'm trying to limit it. We're already at about 20 minutes, and if, like me, you start to zone out around that time, I did try to spice up this next part with some fancy clip art, if you can't tell already from this slide. So let's get into it. Thinking about the pre-visit. I broke that down into websites, registration forms, and then for the waiting room, I'm thinking specifically about visual cues such as posters, pamphlets, restroom signs, and then people they're interact with, like the front desk staff, and policies that we have surrounding formal IDs, insurance cards, etc. In the exam room itself, patient will likely be interacting with your MA and you. Tends to be a lot more conversation, collecting HPI, histories, doing the physical exam, and then documenting in your EMR. So how can we be making each of these steps more inclusive? So starting out, we're talking about the pre-visit with my fancy laptop clip, and we're thinking about your website, making sure to include images of same-sex couples, LGBTQ plus topics in terms of services offered, perhaps things like PrEP or medications for opioid use disorder. And then if you are mailing forms prior, make sure that these forms are inclusive, for example, including ranges for family structures, living situations, things like that. In the waiting room, same concept. We're trying to center images of LGBTQ plus individuals, either on posters or pamphlets, thinking about relevant topics, needle exchange, pronouns, gender-affirming care, and I'm just listing these off for this lecture particularly because we're thinking about LGBTQ plus community individuals with substance use disorders. However, remembering that with intersectionality, it's important that images are reflective of many minority groups and thinking about race, gender, beyond the focus that we have today. Now thinking about our patient, moving towards check-in, interacting with our staff, forms with neutral wording, we briefly touched on, and I'll show some examples of these in the next few slides. I think offering your staff the option of stickers or pins to openly display their pronouns and making sure that all gender restrooms are available, as well as providing regular education with your staff members. I'll stress that all gender restrooms are essential, particularly if you're in drug screening as part of the check-in process at your office. I'll talk more about education resources regarding staff education, but I like to stress it on this slide because the front desk is often the first interaction that patients will have with our clinic, and they can really make or break an encounter. Very rarely are these make or break encounters due to malicious intent of our staff, which is why, again, education on language of inclusivity is so important. Here are just some examples that I really liked of posters. This one normalizing checking state registry for medications each visit, emphasizing that it's part of our health check and not meant to single out individuals. I'd like to give credit for these images to Minus 18 and University of Michigan, who offer free posters and resources on their websites. And in regards to restroom signs, the toilet would be my preferred choice just because it's the most neutral image. Oftentimes we'll see images that involve two stick figures or the combined skirt-pant figure, which some individuals may consider somewhat demeaning or confusing. Delving into how to create inclusive forms, I want to emphasize this is really just a starting off point. There are plenty of examples out there, and I think a huge focus on any forms, and that's why I have it at the top, is leaving a blank, which allows for individual language. You can see it on this slide here. This image is from the Fenway Institute, and each year they release an update on how to collect what's called SOGI information, meaning sexual orientation, gender identity, SOGI or SOGI. They list a lot of options, and they also provide blanks there for patients if they don't feel like the options reflect their identities. I also think about review of systems and allowing for not applicable as an option. This example here is actually what not to do, because many review of systems forms do have this, which are having symptoms separated out between female and male. I would advocate that rather than split gendered items, they are lumped together with options for yes, no, or not applicable. Again, this allows more flexibility in responses and can create a better picture of our unique patient panels. We discussed earlier emphasizing terms like blood relative rather than family history and using parent rather than mother or father. This list obviously could go on, but my goal is just to provide an intro and jumping off point for inclusive forms with non-stigmatizing language. Again, all of this is in an effort to reduce discrimination in the healthcare setting and improve outcomes for our patients. I just briefly wanted to touch on pronouns since I mentioned pronoun pins for clinic staff. For intake forms, typically near patient's name and with a blank present as well, I avoid the term preferred pronouns on paper and in person as it insinuates that correct pronouns are optional rather than part of a person's identity. This infographic from Trans Student Educational Resources has a nice summary on common pronouns, but does not include all pronoun types or options. I also just like to draw attention to this organization because I think they're doing great work, and they have a lot of graphics available for free on their website. You're welcome to use them in any manner, even commercially, which is pretty great for education and made even better as the creators are trans youth. Okay, so now in our fake patient scenario, we've moved on to the exam room. Topics that I'm going to break down here are our language and why it matters, and how we can incorporate more neutral language. Neutral language when collecting histories is essential, as well as only reviewing some of those histories if they're relevant. This may seem like an obvious statement, but several qualitative studies interviewing LGBTQ+ members about interactions within the healthcare system have reported inappropriate questioning regarding sexual orientation or gender identity. For example, if chief complaint was a cough and a provider asked extensive details about gender-affirming surgeries and care, this may come off as invasive rather than inclusive. Overall, emphasizing the importance in engaging patients and educating them on why we're asking sometimes very personal questions of them can go a long way. Additionally, I like to ask permission to document the things that we've discussed into the EMR, and again, being very explicit about why this is important for their health. Patients may face discrimination in areas of the healthcare system and therefore may prefer that certain elements be left out of the electronic record. So, returning to our language, which could be a lecture in and of itself, I've really tried to boil down a few examples of language that I actively work on, particularly terms to avoid and terms to use. And this is both when speaking to a patient, about a patient, or documenting in the EMR. Again, this is why I try to frequently review outside resources to stay up to date on these because several have shifted over time. Non-stigmatizing language as it relates to a substance use disorder, a few examples I've given here are clean or former addict, when really a more appropriate, less stigmatizing term would be a person in recovery or not actively using. The same thing goes for urine drug screens. Rather than referring to them as clean or dirty, it's preferred to use terms such as they're testing positive for this, or they're appropriately negative or appropriately positive for XYZ substance, or as expected. And instead of relapse, which can be very triggering or stigmatizing, using terms like resumed use or recurrence of symptoms. Medication for opioid use disorder is now preferred to medication-assisted treatment. And as discussed in our earlier slides, rather than using terms such as addict or abuser, it's significantly less stigmatizing and has better outcomes to use person-first language, such as person with a substance use disorder. In regards to more neutral language, I recommend using spouse partner rather than husband or wife, and parent guardian rather than mother and father. Common practice previously for documentation was FTM, female to male, or MTF, male to female, and now preferred nomenclature is transgender man or transgender woman. Rather than biologically female or male, a way to indicate this in your notes would be much more appropriate to use the term assigned female or male at birth, and the acronyms for that are AFAB or AMAB. Beyond documentation or patient interactions, I also try to use neutral language when referring to my own spouse or parents. Again, this may seem like a small step, but helps reduce our own bias to have the binary as the default. This slide lists ways that we elicit information, not necessarily to inform you of all the ways that you can, because I'm sure you are all quite knowledgeable on that. It's to reflect on the multiple avenues available because someone might feel more comfortable reporting information online. They also might feel less safe, not knowing who all accesses this information that they're placing into their portal or on forms. When reviewing information that's been put in, just confirming responses, educating on how it helps with complete healthcare can be useful. Oftentimes, asking our patients about sexual health and gender identity can be uncomfortable, especially when it is new or we're trying different techniques. This can also be new for your patients, and they may react negatively. My general approach to these conversations is outlined here. I start with a warning shot, such as, I'm now going to review some personal questions. If you feel uncomfortable answering these questions or would prefer not to answer them, that's okay. I'm asking because it's important for me to know how to take the best care of you and to keep you healthy as possible. If for some reason you do not want me to document your answers in your chart, please let me know. Again, this is providing a warning to the patient, as well as asking their permission to document and allowing them to not answer questions that may make them feel uncomfortable, particularly if it's their first time meeting you. Not all patients want to disclose every detail of their life at that first visit, and that's okay. Depending on the chief complaint, I may go into further details as to why these questions really matter. Some examples on collecting information on gender identity are listed here. Sometimes I am simply affirming that our records are correct. Often I will give examples, particularly if it's a new concept for my patients. For example, our records are getting updated. I want to confirm your gender identity. Options include non-binary, female, male, something else, or don't know. Which of these reflects you, if any? There are a lot of different ways to go through each of these, and I recommend finding out which works best for you. There are also a lot of great resources, including videos and podcasts with different approaches to try out. Some topics that might come up are name used, does it differ from insurance card or driver's license, and which should be used in the patient chart. Sometimes patients want to limit what information goes into their chart, so always ask about documentation of sensitive information. I'll emphasize again that we want to avoid using the term preferred pronouns because it insinuates the gender is a choice rather than who they are. For asking about sexual orientation, again, here's an example of a warning shot. I ask these questions to know how to keep you healthy. You don't have to answer anything you feel uncomfortable with. A mentor of mine likes to use this phrase that I've listed here, which is, tell me about who you share your body with, and then she'll wait and leave the room open for them to answer as they choose. Again, just leaving that space for patients. And if needed, you can add more specific follow-up questions. One of my other mentors, when talking with adolescents and their sexual health, will always be very direct about orifices and types of sex. As we know, asking someone if they are sexually active is not a great way to get a complete history of practices. Overall, you just have to find out what works best for you and your individual patients. For example, I tend towards the phrase, tell me about your partners in the last year, and this gives me an idea not only about physical partners, but also emotional partners, and if needed, I'll be more explicit about body parts of the patient and their partners, often, again, only if relevant for screening and things like that. If you're thinking this is a lot of work and time, you are absolutely right. Reducing stigma and discrimination in healthcare is a lot of work, but it can positively impact individuals and marginalized groups in regards to more thorough care and improved engagement in their health. To help emphasize this as part of standard care, I will often engage patient and medical records, reviewing options and completing as appropriate. These are some examples of how you can document an EPIC. Just be sure to familiarize yourself with the options available in your own EMR. Even during the interaction, I'll turn the screen towards the patient and we'll go through these together. Moving on to the review of systems and physical exam. Again, with intake forms, we outline neutral wording and the importance of not applicable rather than a gendered review of systems. During conversations with our patients, when we're collecting review of systems and exam components, we still want to be maintaining that patient-centered language, neutral language. For example, reproductive health rather than women's health. And when I refer to that patient-centered language, I mean what will make this individual most comfortable, and this can be different for everyone. It also gives warning shot of sorts to patients. Again, this is a common practice in that trauma-informed care. The spiel I use most often is along the lines of, we are doing a pelvic screening today, and I often refer to body parts using medical terms such as penis, vagina. However, some patients are more comfortable with terms such as external genitals, front back parts. What language would make you most comfortable today? Here are some specific examples of how to approach language in a neutral, non-gendered manner. For example, with pap smears, you can use the term cancer screen, and instead of uterus, saying internal organs, instead of vagina, internal canal, and instead of vulva, external pelvic area. The concept of this is outlined in this internal medicine article from 2015 and details the impact on language and increasing cancer screenings in transgender males. Of note, the title is now considered somewhat outdated. Female to male, for example, would be more inclusive as transgender patients assigned female at birth. How we communicate in our medical records can often be limited by our EMR capability. Earlier, we reviewed a way to keep information in patient demographics, and when it comes to individual notes, it is considered best practices to only include gender and sexual orientation if relevant. Classically, we are taught that those one-liners should open with patient age, gender, and complaint. However, gender is notably more relevant in pelvic pain than in chronic cough, and constantly labeling gender identity may result in unintended outcomes of discrimination within the healthcare system. Again, this is just outlining terms for accurate and inclusive documentation. Agender and non-binary patients may use terms such as transmasc and transfemme, and it's important to distinguish that this is different from a transgender male or female. Obviously, this list could go on, but I'm trying to keep to a time limit, and I'll just emphasize again, review with patients what you're documenting, explaining the relevance to their health. For example, if a male comes in for pelvic pain, it's important for me to know if internal organs are still present and if they were assigned female at birth. And this slide is just re-emphasizing the language that we had talked about earlier. We don't need to review it again. And summarizing that inclusivity piece in the clinic environment, we're not just thinking about structural, which obviously is a huge part of it. That would include those posters, gender-neutral bathrooms, as well as our forms. But we also want to make sure that we're educating our staff regularly and documenting in the EMR appropriately while using non-stigmatizing language. Patient education is a huge part of this too. As discussed, we really need to communicate, even over-communicate, and review why this information is relevant. Again, this extends to all of our patients. Having their health and identities reflected accurately in the medical records can be extremely validating. It can increase trust between patients and physicians, knowing that information is being documented appropriately and privately. And a key part of collaborative, inclusive care is regular staff education. And key to any issue is identifying that clinic champion. This should be someone who values education in the topic and is motivated in identifying and arranging regular education for staff members. This may involve regular emails with terminology updates or reminders, reviewing our forms and websites as appropriate. Other examples for trainings include implicit bias. Fenway has a whole series on this. There are also free toolkits and webinars through the University of Michigan that focus on reducing stigma related to opioid use disorder. Many resources are available on trauma-informed care and are echoed throughout both of these other series that I mentioned. This approach can be particularly valuable when working with marginalized populations, outlining techniques towards improving relationships and communication. This is an example of glossary terminology from the Fenway Institute. GLAD also has a very similar version. Finally, reflecting on a bigger picture of stigma within our larger healthcare organizations, this includes ensuring that policies reflect non-discrimination and that includes sexual orientation and gender identity, as well as gender expression. Is there an explicit policy that patients and staff can use restrooms that reflect their gender identity? How often is education occurring for your staff? Do benefits such as healthcare extend to non-traditional family members? And finally, analyzing level of community engagement. First, I think about this as engaging with community champions and organizations that are actively working towards reducing stigma and discrimination. But I also think this should include community involvement to ensure appropriate representation when you're making changes such as updating forms, websites, education, and displays in your clinic. Some resources I mentioned today are listed here, such as Pride in Practice. Recovery Research Institute is the group that puts out the Addictionary. And so this final slide is just me asking that you reflect on your own practice and language, consider ways that your clinic can improve inclusivity, particularly for the LGBTQ+ population. This includes changes that you could make personally in your language, your documentation, and in your interactions with patients. And in closing, I just want to let you know that I welcome any feedback on this presentation, and my email address is listed here. Thank you for your time and attention today.